This is a brief presentation on abdominal aortic aneurysm by Sanjeev Bagga MD. The risk factors for abdominal aortic aneurysm include high blood pressure, smoking, old age more than 70 years. It is more common in whites and if there is a family history of abdominal aortic aneurysm. The signs and symptoms associated with abdominal aortic aneurysm are mainly non-specific, although there can be a pulsating mass in the abdomen. It must be remembered that in very thin persons, a normal aorta can feel like a pulsatile mass. Complications associated with abdominal aortic aneurysm include rupture seen 2 to 4 centimeters below the renal arteries along the left posterolateral wall. If the patient does not die due to rupture, there may be abdominal or back pain, tachycardia, hypotension, distal embolization of the thrombus that may involve the kidneys or the lower limbs, and less commonly, there may be DIC or disseminated intravascular coagulation. The diagnosis of an abdominal aortic aneurysm can be made by an ultrasound or a CAT scan. An ultrasound is recommended for follow-up. A CT scan may be useful both in follow-up as well as if there is a suspected rupture. Open surgery is recommended for rupture. Endovascular stent grafting is best done as an elective procedure. Elective surgical repair is recommended if the aneurysm is more than 5 centimeters in case of women and more than 5.5 centimeters in case of men. The risk of rupture increases 5 to 10% per year as the size of the aneurysm increases. Elective surgical repair of an abdominal aortic aneurysm is recommended if there is an increase in the size of the aneurysm by 0.5 centimeters within 6 months, regardless of size, chronic abdominal pain, thromboembolic events, or iliac or femoral artery aneurysm that causes lower limb ischemia. If a patient has a ruptured abdominal aortic aneurysm and comes with the falling blood pressure, the blood pressure should be kept in 70 to 80 millimeters range, because chances of bleeding increase if the blood pressure is higher. During surgical repair, the aneurysmal part of the aorta is replaced with a synthetic graft. If these iliac arteries are involved, the graft is extended to both the iliac arteries. In case of aortobifemoral repair, flow to at least one internal iliac artery must to avoid vasculogenic erectile dysfunction and pelvic ischemia. If the extent of the aneurysm is above the renal arteries must be re-implanted into the graft or bypass grafts must be created. The endovascular stent grafts have a good short-term results. There are favorable long-term results. Complications include thrombosis and migration of the stent graft. One of the complications of endovascular stent graft is endo leak, which is defined as persistent flow of blood into the aneurysmal sac after endovascular stent graft placement. Follow-up should be done after 1 month, 6 months, 12 months, and every year after the placement of the endovascular stent graft.